concept of oxygenation. So again, our topic for today are about disturbances in oxygenation and utilization. Last week, we started with the concept of oxygenation, the role of the heart as a pumping mechanism. So this time, the role of the lungs, no, which is responsible primarily for gas exchange and utilization. Okay, so our learning objectives for today: one, to review physiology of respiration, to discuss the obstructive disorders as to risk factors, etiology, pathophysiology, symptomatology, its diagnostic tests, and management, and utilize the nursing process as a framework in the care of clients with obstructive disorders. Okay, so the first is review physiology of respiration. So balikan lang natin yung discussion nyo on anatomy and physiology. Okay. For respiration to occur, number one requirement is there is adequate oxygen in the ambient air. As you all know, that the air that we breathe in consists of gaseous mixture. It consists of nitrogen, which is about 78.6%, oxygen, which is about 20.8%, traces of carbon dioxide, which is about 0.04%, water vapor, and other gases that are 0.05%. Add them all, so total of 99.99%. Okay, so the air that we breathe in consists of different gases. And if ever any violation or this first criteria is not done, okay, what are those situations which affect the requirement number one? For instance, those clients who are victims of landslide, di ba natabunan sila ng lupa, there's total absence of oxygen. So therefore, it leads to sudden death. And natabunan sila ng buhay. Okay. Also, those who are victims of smoke inhalation. There is a burn injury, tapos nalock siya, na-trap in a room, and the client was able to inhale superheated smoke and particles of smoke. And naka-inhale siya ng mga carbon monoxide, which has a special predilection or it combined with oxygen. So dapat it combined with carbon monoxide has combination with hemoglobin. Kaya si oxygen ay hindi na i-deliver sa mga body cells. That is the poisonous nature of carbon monoxide. Number two, airway is patent. Meaning, yung daanan ng hangin, airway conducting system is free of obstruction so that air can pass through. 3, respiratory muscles and rib cage are functioning well. So the major muscle of respiration is that of the diaphragm, which is innervated by the phrenic nerve, where the phrenic nerve arises from the cervical cord, from cervical 3 to cervical 5. Therefore, if the patient has cervical cord injury dito sa may bato, one of the manifestations is severe respiratory difficulty, because with damage to the nerve, there'll be weakness or paralysis of the respiratory muscles. 4th, there's negative intrapleural pressure. So what is normally present in the pleural cavity? So that of a small amount of pleural fluid, which serves as lubricant in order to prevent friction between parietal and visceral pleura. So dapat para makapasok yung hangin from the environment, the pressure in the pleural cavity is negative. 5th, diffusion between alveoli and pulmonary capillary bed is effective. So gas exchange occur between alveoli and pulmonary capillary bed. And for that to happen, for gas exchange to happen, there must be a matched ventilation perfusion ratio. Okay. And 6, Of course, the heart is an effective pump. Na inaral natin last week, the heart, the right side, the right ventricle pumps blood to the lungs for gas exchange, while the left ventricle pumps blood to aorta to systemic circulation so that oxygen will be transported to all body cells, and in return, carbon dioxide will be removed from the cells. 7, blood vessels are patent and elastic. So we're talking about the artery, arteriole, capillary, venule, veins. So ito yung pathway for transportation of oxygen. Patency. What could affect the patency of the blood vessels? It could be obstructed by athero and arteriosclerosis. And with that athero, there's deposition of fats and lipids along the intima of the blood vessels. Nagkakaroon ng narrowing and inadequate opening of the blood vessel, and therefore oxygen will not be delivered to the cell. Pag makipot ang daan, no longer elastic, madaling masasabit ang blood cells. Kaya magkakaroon ng thrombus formation. 8. There is adequate RBC and hemoglobin to carry oxygen. Ayun, so this is the one, hemoglobin is the one which carry oxygen, oxyhemoglobin. So patient with severe anemia will have problem with transportation of oxygen. And finally, the tissues utilize oxygen. Okay, again, number 1, there is adequate oxygen in the air that we breathe in. Pangalawa, airway is patent. So we are talking about upper airway conducting system and lower airway conducting system. So the upper airway conducting system consists of the nose, no, the pharynx, okay, larynx, and then trachea. Okay, so we have here the trachea, and then we have the bronchi, okay, the primary, the secondary, tertiary bronchi, and finally to the alveoli, where gas exchange occur. So again, so nose, pharynx, larynx, trachea, bronchi, okay, secondary, primary, secondary, tertiary bronchi, respiratory bronchioles, and finally to the alveoli. So these must be patent, free of obstruction. Now, what can cause airway obstruction? One is accumulation of secretion. Normally, we produce about 100 ml of mucus, okay? But, and we clear our airway of secretions through coughing. Again, we clear our throat of the mucus secretion. But for patients with altered level of consciousness, they are unable to clear the airway of secretions. And therefore, there will be airway obstruction. So the most common cause of airway obstruction is accumulation of secretion. Kaya ang moral lesson, if ever you are caring for clients with altered level of consciousness, tuberous, comatose, you must have this equipment at bedside. At anong kailangan mo? Kailangan
Suctioning.
mo na, correct, kailangan mo ng suction apparatus. Okay? No? So, standard operating procedure yun. All right. Ano pa? If there is, kailan nga magkakaroon ng increase in mucus secretion? Like when there is an infectious or inflammatory processes. Like when there is rhinitis, pharyngitis, tonsillitis, bronchitis, okay? When there is infection or inflammatory process, there will be a vascular response, and there will be exudate formation. Okay, because of increased capillary permeability. Kaya basta na magga, sigurado maraming secretion. Okay, it can also be obstructed by a foreign body. Okay, or bronchospasm. Bronchospasm. When there's broncholaryngosspasm. Halimbawa, you had a patient with allergy. Okay, an asthmatic patient. One manifestation is broncholaryngosspasm. Or dili kaya, another patient has electrolyte imbalance. Hypocalcemia can cause laryngobronchospasm. Okay? And together with that, there's also bronchial edema. Ayan, no? So airway is patent. Then the third requirement, respiratory muscles are functioning well. Okay, respiratory muscles and rib cage are functioning well. So we have here, no? So this is the diaphragm. The diaphragm is the major muscle of respiration. It separates the thoracic viscera with that of abdominal viscera. Okay, and then this diaphragm nga is innervated by the phrenic nerve, which is supplied by C4, and it also get innervations now to C3 and C5. Kaya nga the nerve supplies between cervical third, no, and 5, okay, of the cervical cord. Na pagka may injury nga, no, so dito sa neck, cervical cord injury or spinal cord injury, wherein maraming causes dyan. It could be secondary to penetrating injury, gunshot wound, o kaya stabbing, vehicular accident. Then expect that there will be weakness or even paralysis of the respiratory muscle. And the pressure in the pleural cavity should be negative. So how is it? So we have here the pleura, the covering of the lung. The outermost layer, no, is parietal pleura, and the inner layer is the visceral pleura, which closely adheres to the lung. And the space between parietal and visceral pleura is the pleural space or pleural cavity na mayroon yang small amount of pleural fluid. Okay? Lubricant. Okay. Pressure in the pleural cavity, excuse me. Clear the airway. Pressure in the pleural cavity is called intrapleural pressure. Okay, it is called intrapleural pressure. And atmospheric pressure at sea level is 760 mm mercury. Okay? So yun ang mga pressures ha. Atmospheric pressure at sea level, 760 mm mercury. Pressure in the pleural cavity or intrapleural pressure no, is called intrapleural pressure, which is about 755 mm mercury. And then pressure inside the lung mismo is called intrapulmonic pressure. Okay, as you would see in here, the right lung consists of 3 lobes. Now 1, 2, 3 lobes, and then the left lung consists of 2 lobes. Okay, the upper and the lower lobe. Okay, when the respiratory muscles contract, no, how is the mechanism of inhalation or mechanism of inspiration? Okay, so when the respiratory muscles contract, pag nag-contract ito, together with intercostal muscles, then the diaphragm will go down. The diaphragm will go down. Dahil bumaba si diaphragm, then lalaki yung thorax. The thorax will increase in size. And so the intrapleural pressure will decrease. And lung will increase in size, and intrapulmonic pressure also decreases. So ano nga yung pressure dito sa pleural cavity or intrapleural space? That is negative. Pag negative, meaning below 760. Pag positive, above 760. So again, when the respiratory muscles contract or the diaphragm contracts together with the intercostal muscles, it goes down. So thorax will increase in size. So intrapleural pressure will decrease to about 755 mm mercury. Okay. And then lungs will increase in size. Intrapulmonic pressure will decrease. Kaya air from the environment papasok sa lungs. So you have good lung inflation. Inspiration is completed. While what happened during exhalation or expiration? So this time, the diaphragm naman will go up. The diaphragm will go up. So ano mangyayari ngayon sa thorax? Dahil si diaphragm ay umakyat, then the thorax now will decrease in size. And our interpleural pressure now will increase from 755 no, to 757. Okay? And lungs no, will decrease in size. And intrapulmonic pressure will rise from magiging 763. Kaya air lalabas from higher to lower pressure. Carbon dioxide is excreted. Okay. So, pagpasok, movement of air in and out of the lungs, in pagpasok at paglabas ng hangin is called ventilation. Okay? Yung tinatawag nating ventilation. Movement of air during inhalation and movement of air out during exhalation is called ventilation. And another term, movement of gas from higher to lower pressure is called diffusion. Okay? Pag may pressure na pinag-uusapan, that is called diffusion. Okay. So, what can affect the condition number 3? Wherein the respiratory muscles and reflexes are functioning well, pagka nga may electrolyte imbalance, pagka may cervical cord injury. How about number 4? Intrapleural pressure is negative. What can cause positive intrapleural pressure? Nasaksak, na aksidente, okay? Gunshot wound, penetrating injury. So dito sa my lungs, there's damage to the blood vessel. So nagkaroon ngayon ng bleeding. Blood accumulate in the pleural cavity. Or there is accumulation of air, pneumothorax in the pleural cavity. Basta may chest trauma, nasaksak, nabaril, magkakaroon tayo ng pneumothorax. So therefore, ano ngayon ang pressure sa pleural cavity? Hindi na negative, it becomes positive. It could be 763, 765, depending upon the volume of air and blood in the pleural cavity. So therefore, makakapasok ba yung hangin dito? Eh, di ba sa atmosphere ay 760, tapos dito sa pleural cavity ay 763, hindi makakapasok ang air. Kasi di ba sabi natin, para makapasok ang hangin, the pressure in the pleural cavity is negative. So kung hindi makakapasok ang hangin, lungs will collapse. Hindi mag-expand ang baga. Okay? So, again, itong ating airway natin. Ayan nga yung nose, pharynx, larynx, trachea, bronchi, okay, primary, secondary, tertiary bronchus, bronchiole, terminal bronchiole, and finally, to the alveoli. Airway is patent. So, isa, alveolus. Pag marami, ayan, marami, that is alveoli. At nakikita nyo ito, yung blue. So, this is the pulmonary artery and capillaries. And the red, yung pulmonary veins. So, gas exchange occurs mismo between alveoli and pulmonary capillary bed. Ayan, no? So, this is the bronchiole, no, with alveoli. Each sphere is an individual alveolus, and this is the site of external respiration, meaning the exchange of gases between alveoli and blood capillaries. Okay. So, isa, marami. Tapos yung mga blue na yan, yan yung ating mga blood vessels, the pulmonary capillary bed. Okay, bigger view. Sa alveolus, marami alveoli. Okay, na andito yung ating pulmonary artery, in which the right ventricle pumps blood to pulmonary artery to the lungs to take in oxygen. Naalala mo yung ating cardiopulmonary circulation last time. And the pulmonary veins carry oxygenated blood to go back to the left atrium, left ventricle to be pumped, systemic circulation. So, kunin natin isang alveolus. Okay. Na-meet natin yung criteria. There's adequate oxygen in the ambient air. Pangalawa, airways pattern. Pangatlo, respiratory muscles and rib cage are functioning well. By the way, yung rib cage na sinasabi natin, ito yung sternum, no, which consists of the 12 ribs. No? 7 ribs are attached to the sternum, while the 8 to 12 ribs are considered the false ribs. And among these, 11 to 12 is floating ribs. Okay. So, na-meet natin yung criteria. The respiratory muscles and rib cage are functioning well. There's negative intrapleural pressure. Nakapasok yung hangin, di ba? So, there's movement of gas from higher to lower pressure. Kaya, we have good lung inflation. We have good lung inflation. Expanded ang lungs natin. So, in the alveoli, in the lungs, there is increased concentration of oxygen. So, there's good ventilation. Okay. Now, on this side, ito yung ating pulmonary capillary bed. Pulmonary capillary bed. On this end is the pulmonary artery. And on this end is the pulmonary vein. Pulmonary artery carries unoxygenated blood. Yung pinam ni right ventricle. There's high concentration of carbon dioxide in the pulmonary capillary bed. So, therefore, magkakaroon ngayon ng exchange of gases. There will now be exchange of gases between alveoli and pulmonary capillary bed. Oxygen will go to the pulmonary capillary, while carbon dioxide will go from the pulmonary capillary to the alveoli. So this is now the actual exchange of gases between alveoli and pulmonary capillary bed. Ito na yung gas exchange. And gas exchange which occur between alveoli and pulmonary capillary bed is called external respiration. And the movement of gas from higher to lower pressure is called diffusion. Again, fully expanded ang lungs natin. There's good lung inflation, high level of oxygen. Whereas sa pulmonary capillary bed, sa pulmonary artery, arteriole, high levels of carbon dioxide. Kaya magpapalitan ngayon, oxygen will go to the pulmonary capillary bed and carbon dioxide will go to the alveoli. And when we exhale, carbon dioxide is excreted from the lungs. Okay? For gas exchange to occur or for diffusion to occur, there must be much ventilation perfusion ratio. Meaning, there must be good ventilation and good perfusion. Ano ngayon yung term perfusion? Perfusion refers to amount of blood flow to the pulmonary artery. Okay, pulmonary perfusion refers to the amount of blood which flows to the pulmonary artery. Okay, di ba sabi natin, the blood vessels must be patent, must be elastic. Anong pwedeng bumara? Anong pwedeng bumara dito sa pulmonary artery? Diba? Pwedeng magkaroon ng pulmonary embolism. Pulmonary embolism. It could be a dislodged blood clot na galing sa lower extremities. Okay? May deep vein thrombosis siya sa paa because the client is bedridden, no? Paralyzed, no? There's decreased mobility. No? So, pwede siya magkaroon ng DVT, deep vein thrombosis, at nabakbak, nabaklas, bumara. It goes with the circulation. And bumara dito sa pulmonary artery branch. Okay? Pwede rin magkaroon ng air embolism. Saan galing yung air embolism? Ay galing yon sa IV therapy o kaya blood transfusion therapy. Okay? So kasi hindi na patent yung ating pulmonary artery. Or di kaya may problema siya sa right ventricle. Right ventricular failure. The heart does not pump adequate blood papunta kay pulmonary artery to take in oxygen. Okay? For gas exchange to occur or for diffusion to happen, there must be much ventilation perfusion ratio. Kung ganon, ano ang mga mismatch? Ano yung mismatch ventilation perfusion ratio? Okay, I'll give you an example. There are plenty of secretions. Barado ang airway. There are plenty of secretions. Hindi nakapasok ang hangin. Ano mangyayari? Ano mangyayari sa lungs? Hindi siya mag-expand na mabuti. So there could be partial or complete lung collapse, atelectasis. O dili kaya, may bronchial tumor, mayroon siyang bronchial cancer or laryngeal cancer. It can also cause airway obstruction. So, it will affect ventilation. Okay? Or pneumothorax, hemothorax, positive intrapleural pressure. So, hindi makakapasok ang air. Lungs will be collapsed. Okay? So, ano mangyayari? Kung si lungs ay maliit, collapse, andito ngayon si pulmonary artery which carries unoxygenated blood. Tanong, magkakaroon ba ng gas exchange?
Hindi po.
Hindi. So, tama yun. Anong mangyayari ngayon? The unoxygenated blood will go back to the pulmonary vein, to the left atrium, to the left ventricle, and being circulated in the body. Kaya anong itsura ng pasyente? So the patient,
Nag-blue po.
okay, there will be severe difficulty of breathing at saka cyanotic siya, bluish yung pasyente. At yung mismatch na to, wherein there's low ventilation, although may normal perfusion, ay shunted unit. Madaling maalala, shunted, kasi unoxygenated blood is being shunted back to the heart, to the left side. Okay. Another. Ito naman ang may bara. May bara sa pulmonary artery. May bara dito nga sa pulmonary artery, may thrombus o kaya embolus. Okay. At saka yung ating kung naalala nyo, hemodynamic monitoring natin sa araw, naiwan na naka-inflate yung balloon. E di babara yan. Babara yan dito. Okay? Babara siya sa pulmonary capillary. Pero si lungs, okay. Expanded. Pero may bara dito. So therefore no blood flow. No blood will flow to the pulmonary capillary. Walang perfusion. Tanong ulit. Will there be gas exchange? Yes or no?
No.
No, thank you. Okay. Walang gas exchange. At anong mangyayari? Ano mangyayari dito sa lungs na to that being supplied by that pulmonary artery branch? It will not receive adequate blood flow. And what will happen to the lungs? The lungs will die. Okay, yun yung pulmonary infarction. Magkakaroon ba ng gas exchange? Wala. So therefore, an area of the lung without gas exchange is called dead space unit. Nabanggit ko na rin sa inyo yun last time, no? That is called dead space unit. Meaning, dead space, an area of the lung without gas exchange. Okay? And then, the third, mismatch. Naku, may hemothorax. May massive hemothorax and pneumothorax kasi victim nga siya ng chest trauma. Tapos, meron din pala siyang pulmonary embolism o kaya meron pala siyang right ventricular failure. E di, barado din ang pulmonary artery. Maliit din ang lungs. Lung is collapsed. So, magkakaroon ba ng gas exchange? There is neither ventilation nor pulmonary perfusion. Oh, may gas exchange ulit? Yes or no?
No.
No. Thank you. That brain. Okay? And that is incompatible with life. Ibig sabihin, hindi natin mabubuhay ang pasyente. Okay? Unless emergency intervention is done. Unless emergency intervention is done. Okay. Kaya ang mismatch na to, ang tawag dyan, silent unit. Okay? I hope nagbasa kayo ng textbook, no? Para mas na-enjoy nyo. Silent unit. Kasi, tahimik na yung pasyente. Wala nang buhay. Patient is already dead. Okay? Mabubuhay natin unless emergency intervention is done. So, kung maraming ang secretion, suctioning. Di ba? We have to suction the nose, pharynx, larynx. At pag maraming lower airway secretion, kailangan niya talaga ng artificial airway, endotracheal tube. Pero ang endotracheal tube kasi, magagamit lang natin yan for about 1 week. So in most hospitals, pag 1 week na naka-ET, they have to create a more permanent artificial airway, which is maglagay na ng tubo dito sa neck, tracheostomy, para masuction natin. Kaya that could be an indication. Patient is comatose or stuporous, tapos may severe hypoxemia, no? Kailangan natin ng artificial airway. All right. No? Pagka may pneumohemothorax, let's regain back the negative interpleural pressure. So tatanggalin yung air, tatanggalin yung fluid by thoracentesis o dili kaya by the insertion of the tube, thoracostomy tube. Ayun. Ngayon, dito naman, halimbawa, may pulmonary thrombosis. Palagay mo, pharmacology ngayon. Anong gamot ang bibigay natin pagka may thrombus pala na nakabara sa pulmonary artery? Pag may nakabara sa pulmonary artery, pharmacology. Anong gamot ang bibigay natin to dissolve the blood clot? Anong gamot bibigay natin to dissolve the blood clot? Heparin is just a follow-up therapy because heparin will not be able to dissolve the blood clot, but it will prevent future blood clot formation. A drug which will directly dissolve the blood clot is called thrombolytics. Ibang gamot na binigay din natin sa may MI na may bara sa coronary artery. Thrombolytics, it will directly dissolve the blood clot. Example, yung ating TPA, tissue plasminogen activator, or dili kaya yung ating streptokinase. It will directly dissolve the blood clot. Okay? So yun. Address the cause. And because the patient has severe hypoxemia, kailangan niyang ikabit sa mechanical ventilator or respirator. Okay? So there must be, for diffusion to happen, there must be much ventilation perfusion ratio. Okay, let's have a drill. Exercise tayo. You tell me whether this condition is a shunted unit, dead space unit, or silent unit. Okay. 1. Laryngeal tumor. Laryngeal tumor. Please answer. Sumagot pag kinakailangan. Okay. Almira. May laryngeal tumor, hindi nakapasok ang hangin?
Dead space po.
Hindi. Nasa larynx tayo, laryngeal tumor. Analyze. Hindi nakapasok yung hangin. So that is shunted unit. Correct. Okay. Patient has right ventricular failure. Right ventricular failure. Hindi nakapump ng adequate pulmonary perfusion. Paano yan?
Dead space.
Correct. That's dead space. Client has pneumothorax.
Silent unit.
Silent space.
So pneumothorax, hemothorax, that is shunted unit. Okay. Patient has atelectasis with pulmonary embolism.
Dead space.
Dalawa yun ha. Patient has atelectasis, nag-collapse ang lungs, tapos meron din siyang pulmonary embolism. Combined, that is Silent unit. Correct. That's silent unit. Okay? Please remember, no? So, maintindihan na kung naalala nyo lang itong pinag-aralan natin physiology of respiration, ay madali na maintindihan ang ating mga disorders. Okay? So, ituloy natin, di ba? Diffusion. Ano yung susunod? The heart is an effective pump. And then the blood vessels are patent and elastic. And then there's adequate RBC and hemoglobin to carry oxygen. And finally, the tissues utilize oxygen. So, pagdating dun sa cell na na-deliver yung oxygen and carbon dioxide is removed from the cells, ito na yung internal respiration. Di ba? Ang external respiration is the exchange of gas dito mismo between alveoli, pulmonary capillary bed. Kasi yung hangin galing sa environment na pumasok sa lungs. Kaya, external respiration. While, nung dinala na ni hemoglobin, oxyhemoglobin, ang ating nakarating na sa cell, and in return, carbon dioxide is removed from the cells, yun na yung internal respiration. So the carbon dioxide is removed from the cells, and it passes through the veins, the superior and inferior vena cava, and then bumasok sa right atrium, to the right ventricle, to the lungs, and finally, na-exhale yung carbon dioxide na natanggal during exhalation. So that's the whole concept of respiration or oxygenation. Okay. Questions so far? So start na tayo dito sa ating disorders. Okay. So let's now start with the first disorder. Oh, we have here the lungs. No? The lungs are light, na magaan. Nakakita na siguro kayo ito sa palengke, no? Na nakasabit, no? Okay, sa mga tindahan. So the lungs are light, porous, elastic. It inflates during inhalation and it deflates during exhalation. Ayun, nakikita nyo, no? So yung ating airway conducting system are patent, no? Kaya nakakapasok, maluwag na nakakapasok ang oxygen, nakakalabas yung carbon dioxide. So therefore, the disorders that we're going to discuss now are that of obstructive disorders. Ang mga pag-uusapan natin, may bara sa airway. Okay. So, we call this CAL, chronic airflow limitation. A group of chronic lung diseases that includes bronchial asthma, chronic bronchitis, emphysema, and bronchiectasis. Okay. So the new name is CAL. Pero local board exam, ginagamit pa rin nila ay term COPD, chronic obstructive pulmonary diseases. With new book edition, dalawa na lang ang natira with COPD. Ano yung dalawa na yon? Chronic bronchitis and emphysema. Tinanggal na yung bronchial asthma because initially, bronchial asthma is reversible. Na symptomatic siya for several minutes, 30 minutes, 1 hour, tapos walang 2 hours, na-reverse. Okay na ang pakiramdam ng pasyente. Okay? Pero, asthma is reversible kung na-identify yung etiologic agent. Ano bang yung dahilan talaga? Taga-asthma siya. Okay? Na-address yung cause. E di hindi na mauulit. Pero kung hindi na-address ang cause, ang asthma niya ay tumanggal ng 1 year, 2 years, 3 years, and more, then chronic na rin siya. Chronic bronchial asthma. Okay. Now, the most common cause of COPD. Anong most common cause? Board question. What's the most common cause of COPD? Sagot, the most common cause? Cigarette smoking. What is in a cigar? Anong nandun sa sigarilyo? Sa sigarilyo, a cigar contains several substances and chemicals which when inhaled cause damage to lung structure. Okay? Hindi lang COPD, but also cancer, especially lung cancer. And it is also a risk factor for all types of cancer. Okay? So the most common cause being that of cigarette smoking. At yung pa rin, no? It contains nicotine, no? Sabi nga kanina dito sa chat, it contains nicotine, no? And it causes vasospasm. And therefore, it affects the blood supply to all the body cells. Okay. And the four are related to one another. One could be a complication of the other. One could be a complication of the other. Like bronchial asthma, no? Chronic bronchial asthma can lead to chronic bronchitis. It can lead to emphysema. It can lead to bronchiectasis. One could be a complication of the other. Again, pwede lagyan nyo ng arrow. Okay, asthma can lead to chronic bronchitis. It can lead to emphysema, can lead to bronchiectasis. Asthma, chronic bronchial asthma can directly cause emphysema. Okay, nakuha po. The most common cause is cigarette smoking. But patient can have emphysema even he is not a smoker. Okay? Among the four, si pasyente pwedeng mag-emphysema kahit hindi siya smoker. Because emphysema has a familial predisposition or genetic predisposition to deficiency of alpha-1 antitrypsin. So may genetic predisposition na pagkulang ng alpha-1 antitrypsin, there'll be destruction of lung structure. The most common cause nitong apat is cigarette smoking. Okay. The signs and symptoms overlap. The signs and symptoms overlap. Ibig sabihin, pagka may airway obstruction, may increase in mucus secretion, so therefore, iuubo. So, may increased mucus, may plema, may wheezing, no? May crackles, may difficulty of breathing. Pag nahirapang huminga, makita mo flaring of alveoli nasi, rapid ang breathing, kaya nagkakaroon na ng altered breathing pattern. There's intercostal retractions. Okay? May ubo sila. Nahirapang huminga. So signs and symptoms overlap. Asthma, no? So we'll have difficulty of breathing, no? We'll have increase in mucus secretion. At pagka may mucus, protective mechanism ay iubo, ilabas. Okay? The signs and symptoms are also observed with chronic bronchitis, emphysema, and bronchiectasis. Signs and symptoms overlap. Now, bronchial asthma, bronchitis, bronchiectasis affects the lower airway. Asthma, 1, 2, 4 affects the lower airway, while emphysema affects the alveoli, wherein there's abnormal hyperinflation of the alveoli of the lungs. Okay? Now, ano pa? Tatlo of this, because of airway obstruction, hindi nakapasok ang hangin, there'll be abnormal ABG. There'll be abnormal ABG. Ano yun? There's respiratory acidosis and hypoxemia. Isa lang dito ang pwedeng magkaroon ng normal ABG at the start. Yung si emphysema. Diba? There's good lang inflation, hyperinflation pa nga, okay? Initially lang. Pero as condition progresses na hyperinflated ang alveoli, naglolobo yung alveoli, puputok yun, magra-rupture. And therefore, magkaroon na tayo ng decreased area for gas exchange. Eh di, abnormal na din yung kanyang ABG. Okay? So kaya ang management natin sa apat na yan ay almost the same. Kailangan mo ng bronchodilator, kailangan mo ng mucolytic, kailangan mo ng expectorant, corticosteroids. Patient needs nebulization. Na? So, kailangan niya ng suctioning. Okay, chest physiotherapy. lahat ng mga procedures na ginawa nyo, okay, respiratory procedures applicable for our patients. All right? So, with that brief introduction, proceed tayo sa first disorder, bronchial asthma. All right? It is defined as intermittent and reversible airflow obstruction affecting the airway. Ayan, kita mo, no? Intermittent, pasupong-sumpong, reversible. Reversible. Nasabi ko nga, no? Yung nahihirapan huminga siya ngayon, no? Kumakapal yung labi, no? And then, nahihirapan na siyang huminga. There's wheezing. Nakakain kasi siya nung kanyang allergen. By the way, si bronchial asthma, siya lang yung talagang allergic in nature. Maraming causes, pero it is related to allergen. Okay? So nakakain siya. Ano ba yung mga nakaka-allergy? Ito yung mga high protein, mga seafoods, the chicken and egg. Okay?
Hipon.
So, it is reversible. In 2 hours, okay na siya. So the obstruction is due to inflammation of the airway. There is hyper-responsiveness, meaning there is bronchospasm, there's bronchoconstriction. There's bronchospasm, there's bronchoconstriction. So ito yung ating airway, all right? Ito yung normal bronchial. The airway is patent, walang bara. So take a look dito, sa asthmatic bronchial. There is an airway obstruction. What is the cause of airway obstruction? Ayan, namamaga. There's bronchial edema. Okay, so there is bronchial edema and there's increase. There's bronchial edema and there's increase in mucus secretion. Paano naman makadaan dyan yung hangin? Okay, so again, another slide. And dito yung ating airway. Relax ang bronchial smooth muscles. There's no muscle tightening. Pero take a look dito sa ating right side. Ayan. No? So there is bronchoconstriction, there's bronchospasm, okay, plus there's bronchial edema, and there's increase in mucus secretion. The airway lining is swollen and red. And there's airway obstruction. And what are among the etiology? The number 1 etiology is exposure to allergens. Allergens na to can be inhalants, something we inhale, ingestants, something we eat, or even contactants. Okay. So, also, with exposure to cold air or dry air, at yung mga airborne particles. Airborne particles. Ang pangkaraniwan yung dust. Kaya nga pagka tayo ay magda-dusting, siguro naman naglilinis kayo sa bahay, sa kwarto, pagka may maraming alikabok, pagka magda-dusting kayo, dapat ang gagamitin natin yung wet na rag, wet na basahan. Huwag yung dry, no? Tapos pinagpag mo pang ganun. Dinalanghap mo lahat yung alikabok. No? So mayroon talagang iba na mayroon talaga siyang allergy. Okay? Kaya aatakihin siya ng kanyang asthma. Okay. And it could also be secondary to microorganism and even allergy to aspirin. Meron din tayong exercise-induced asthma. Okay? So ano yung ating mga inhalants? Could be pollens, no, dust mites, mold, pet dander, okay? NCLEX question para to prevent or minimize the attack or decrease the attack of asthma. So saan daw dapat nandoon ang mga domestic pets? Siyempre yung mga alaga natin dapat nasa labas ng bahay. Okay? Pero ngayon nga, no, 'di ba? Lalo na nitong nag-pandemic, pinagkakalibangan natin hindi lang plantitos, plantitas, no? Marami din tayong mga alagang pusa, alagang dog, no? Mga imported, no? Okay? Natapos nasaan sila? Nasa bahay, nasa loob ng bahay, nasa loob ng kwarto, kasama sa pagtulog, yakap-yakap. Okay? So, Buti kung wala kang allergy sa alaga mong hayop. Pero prevention is the pets should be outside home. Okay? So what are other causes? What are other causes? Too much exercise, no? Too much exercise, no? Nag-aerobic siya, no? Nang matagal, marami na siyang nagamit ng oxygen, kaya hinabol na niya ang kanyang paghinga. Okay? Kung iyon ay related to exercise, so we call that exercise-induced asthma. It can also be secondary to microorganism nga, di ba? Or even viruses, no? Or there is an upper respiratory illness. Or for unknown reason, idiopathic. Meron siyang bronchospasm. For unknown reason. So, hindi natin alam. All right. So, what happened? Upon exposure to allergens, especially nga yung mga inhalants na yon, contactants, okay, it would cause injury to the mast cells of the respiratory tract. And the antibody responsible for hypersensitivity reaction is antibody E. Okay. So upon exposure to etiologic agents, this would cause injury, tissue injury, and the injured cells release chemical mediators. What are these chemical mediators? No? So these are histamine-like substances. Histamine, leukotriene, bradykinin, IL-4, interleukin, eotaxin. These are chemical mediators. These are vasoactive-like substances, meaning it causes effect on the blood vessels. So the vascular response is momentary vasoconstriction followed by vasodilation. Ayan. So there's blood vessel dilation. So meaning there's increase in blood flow and increase in blood hydrostatic pressure. Increase in blood hydrostatic pressure and increase in capillary permeability. Kaya magkakaroon tayo ng fluid shifting from intravascular to interstitial spaces. And therefore, there will be tissue swelling, bronchial edema. And because of the fluid shifting from intravascular to interstitial, hindi lang mamamaga, there's increase in mucus secretion. So this is the concept of inflammation. Pagka na-inhale natin yung ating allergen, ingestants, inhalants, there'll be injury to the mast cells of the respiratory tract. And the injured cells release chemical mediators. Ayan, no? Chemical mediators which has effect on the blood vessels. Kaya it starts the vascular response. Ano nga yung vascular response? There's momentary vasoconstriction followed by vasodilation. Pagka nag-dilate ang blood vessel dito sa respiratory tract, there'll be increase in blood flow. Mamumula. And there'll be increase in blood hydrostatic pressure. Kaya magkakaroon tayo ng fluid shifting from intravascular to interstitial space and increase in mucus secretion. Okay? So, just please remember, kahit saan, halimbawa nahiwa ka, nasugatan, same process will happen. Now, there's tissue injury. Okay? And leukotriene, basically, or primarily, is the one which causes bronchospasm. Okay? So, if the cause is secondary to allergen, we call it atopic or allergic asthma. Okay? Atopic or allergic, meaning there's genetic tendency to develop allergy. Genetic tendency. Kaya hindi lahat naman ay naa-allergy sa seafoods and the chicken and egg. Okay? Atopy is associated with heightened immune response to common allergens. Okay? So pag ang cause ay allergy, then we call this atopic or allergic asthma. Kung hindi ma-identify kung ano yung asthma niya, therefore, tawag natin doon simply bronchial asthma. Alright? parang yung anak ko no, about 2 to 3 years old. No, may alaga kaming mga 45-day-old chicken, no? After 45 days ibebenta na. Ay, napakahilig nung anak ko na to sa sisiw. Talagang kinukuha niya yung sisiw at saka nilalagay pa niya sa pisngi niya. Hinahalik-halikan. Pumapasok siya sa loob ng kulungan. Okay? Ng manok. Pero hindi siya na-allergy. May alaga din kaming pusa at saka aso. Tapos kulambo pang ginagamit namin noon. Wala pa kami mga screen. Okay, no, nag-umpisa kami ng buhay, nag-umpisa kami ng pamilya, may kulambo. Nandun yung dagang costa, nandun yung rabbit sa loob ng kulambo. Mahilig sa pets, no? Yung husband ko uuwi, tuwan-tuwa naman yung bata. Okay? Wala siyang allergy. Pero one time, nagkaroon siya ng atake. Asthma. Na-recall ko, nag-a-asthma siya. Kasi pagka bumaba, may alaga kaming yung tawag doon, yung manok na hindi 45 days, na Tagalog, manok na Tagalog. May mga pugad. Pagka pumutak na yung, nag-ingay na yung manok, bumaba na sa pugad, ibig sabihin ng itlog siya. Hihingi niya yung itlog. Fresh egg. Iinumin. Hindi nga sinasama sa SARC. Okay, so araw-araw, no, umiinom siya ng itlog na yon. Doon ko naalala na doon siya nag-atake, no? Pero na-eliminate namin, no, yung expose siya sa mga feathers, no, pero di nagka-asthma, yung pala allergic siya doon. Kaya isang beses, 2 beses na nag-atake, and then doon namin na-identify. Kaya ngayon, bawal na pala sa iyo ang fresh egg. Okay? At wala nang atake. Na-eliminate na kasi yung allergen, yung triggering factor. Okay? So with this, ano ang nursing diagnosis? Applicable? Parado ang airway? Ineffective airway clearance. Related to bronchospasm, bronchial edema, increased mucus secretion. Ano pa? The patient will have DOB. There is rapid breathing. Nursing diagnosis number 2, altered breathing pattern related to, etiology? Related to increased mucus secretion, bronchial edema, bronchospasm. Pangatlo, kung poor ang ventilation, low ventilation, edi poor ang ating gas exchange. Impaired gas exchange related to bronchial edema, bronchospasm, increased mucus secretion. Okay? Our dear students, magagamit mo lang yung altered breathing pattern pagka hindi na normal ang kanyang respiration. Pero in adult, 12 to 20 breaths per minute. Magagamit mo yung nursing diagnosis number 3, impaired gas exchange, pagka meron kang ebidensya. Anong ebidensya mo? ABG. Abnormal ang kanyang ABG, there's retention of carbon dioxide, and there's hypoxemia. Okay? So, anong physical assessment? There's audible wheezing, an increase in RR, acute episode. There is wheezing is louder during exhalation, meaning there's inspiratory and expiratory wheezing. Audible. Ano ibig sabihin ng audible? Ibig sabihin, maririnig mo yung huni ng kanyang paghinga even without stethoscope. Okay? Audible wheezing. That's the earliest manifestation. And of course, no, there's DOB, there's flaring of nasi, no? There is intercostal retractions, rapid ang breathing niya, okay, mabilis, no? There's tachypnea, at di ba, there's increasing mucus secretion, di dapat mailabas ito. So there's productive cough. And patient use accessory muscles of respiration, kaya nagkakaroon siya ng intercostal retractions. Okay, so chronic bronchial asthma is reversible, intermittent, pero kung hindi na-identify nga, no, na known asthmatic na siya for several years, okay, then we call that chronic asthma, and there will be air trapping. Air is trapped inside, no, Kasi mahirap ang paglabas ng hangin. And to accommodate the air which is trapped inside, there will be increasing anteroposterior diameter of the chest, and that is called barrel chest. Okay? ABG reveals hypoxemia and respiratory acidosis. So patient, severe type na will have cyanosis. There's poor O2 saturation. Monitor natin ang O2 saturation, di ba? By the use of pulse oximeter. Ayan. So, dapat may pulse ox kayo sa bahay. So, gagamitin hindi lang sa RETDEM. Magagamit din nyo even in your own home for your own family. Okay? Kasi ang ABG po ay kailangan pa ng blood sample. Diba? Pero with ABG, kompleto yun, it will give us an idea. Miss Marasigan, paki-mute please.
Sorry po.
Okay. So with ABG, makukuha natin mismo yung blood pH, no? Yung PaCO2, PaO2. Kaya lang, hindi naman tayo pwedeng mag-ABG every now and then. Kaya simply, by the use of pulse ox, ma-monitor natin yung O2 saturation, no, which is about 95% to 100%. Okay? And then, because of hypoxemia, there'll be altered tissue perfusion. Kaya altered cerebral perfusion. Pwede magkakaroon tayo ng alteration in the level of consciousness. Patient can have disorientation, can have confusion, restlessness. So tingnan nyo lang po mga anak ha, assessment. Pag ang pasyente nyo ay masyadong magalaw, no, disoriented, restless, pangit ang oxygen to the brain. Okay? And there is tachycardia due to hypoxemia. Okay? So again, andito yung ating normal airway, relax, no? Ang ating bronchial smooth muscles. And on the right side, there is a bronchospasm, there's bronchial edema, and increased mucus secretion. Kaya yun ang signs and symptoms, there's cough, shortness of breath nga, wheezing, masakit sa dibdib, no? Chest tightness, and increase in mucus secretion. Kaya hawak nila ang kanilang dibdib. Nakakamatay ba to? Severe asthma, napakasakit pala yun sa dibdib. It can cause death. Okay? It can cause death. Iano ko lang yung isang taga sa amin sa church. Ay, my age, siya ay known asthmatic. Kaya parati siyang may inhaler. Ngayon, fiesta mismo, sa kabilang baryo siya, fiesta sa kanila, may misa. Nag-assist sa misa. Okay? Nag-assist kasi siya sa misa. Tapos sa susunod posisyon, siyempre sa posisyon, ang ginamit, kandila. Nalanghap niya yung mga usok. And had an attack, acute attack of asthma, difficulty of breathing. Pag dukot niya sa bulsa, ay, wala pala dito yung inhaler ko. Kaya sabi niya, sige, uwi ako. No? Uwi siya. Kasi doon yung prosesyon sa side na yun, ay dito yung bahay nila. And then, nung palang nasa bahay na, talagang sobra na yung difficulty of breathing, and therefore was brought to the nearest hospital sa Malolos, no, sa Sacred Heart Hospital. Pero unfortunately, pagdating niya doon, DOA na siya. Dead on arrival. Kaya nagkagulatan sa baryo. Kanina lang nandito si Nene, no, nag-assist nga sa misa. Okay? Kasama sa prosesyon, tapos bigla na lang napatay na pala. Ayun, kaya sabi ko sa inyo, it can cause sudden death with acute asthma. Okay? So ano yung mga laboratory assessment? Ayun, ABG, arterial blood gas, na magkakaroon tayo ng one session mismo for the lecture ni Sir Nicolas, no, on ABG interpretation. There's also elevated eosinophil count and elevated IgE levels. Okay, eosinophil also increases, no, in the presence of allergy. An antibody responsible for hypersensitivity reaction is antibody E. And most accurate test for asthma is pulmonary function test. Most accurate test, pulmonary function test. Ano yun? It will determine lung volumes and lung capacities. Gaano ba ang kapasidad ng lungs? Gaano ang volume na papasok sa lungs? So, ito yung ating paano ginagawa. And ito yung ating equipment. It has a mouthpiece. No? Siyempre, mouthpiece, pasok sa bibig. Tapos, clip the nose. And then the client will do deep breathing. No? Hinga ng malalim, exhale, and gano'n. No? At mamimeasure ang lung volumes and capacities. Okay? Tulad nito, ano nga yung tawag sa normal effortless breathing? Normal effortless breathing is called eupnea. Normal effortless breathing is called eupnea. At sa adult, 12 to 20 breaths per minute. Tayo ngayon ay komportable. We are seated comfortably. I am sitting comfortably. Okay, pakimute, pakimute please. Okay. We are seated comfortably. Gaanong hangin ang papasok sa baga? The volume of air which will be inhaled and exhaled with normal effortless breathing is called PV. Ayan yung normal effortless breathing. Ito naman yung pag huminga tayo ng malalim. So, yung normal effortless breathing, eupnea. Na gaano ang volume na papasok sa lungs is about 500 ml. So sabi ko nga, tayo ngayon, no, walang hinihika ngayon, walang nahihirapang huminga, no? It is automatic, no, na humihinga tayo, okay? The volume of air na mapapasok at mailalabas natin with normal effortless breathing is called tidal volume, and the volume is called 500 ml. Okay. Now, everybody, please, in your own home, do deep breathing. Huminga ng malalim. Inhale, exhale, inhale, exhale. Meaning you're doing diaphragmatic breathing. Okay, inhale. Na paghawak mo yung kamay mo, yung tiyan mo papasok at exhale, lalabas. Inhale, exhale. So, when you do deep breathing, ito yun. Nung huminga ng malalim, gaano daw ang papasok? Total lung capacity. So, the volume of air which can be inhaled with maximum inhalation. The maximum air na papasok sa lungs with maximum inhalation is called total lung capacity. At gaano ang kasya? 6,000. Up to 6,000. So, depende kung gaano kayo kalalim huminga, no? It could be 5'8", could be hanggang 6,000. From the point of maximum inhalation, how much can be exhaled? So, that is called VC. That is called vital capacity, which is about 4,800. And what is the volume remaining in the lungs? That is called residual volume. Again, when you do the breathing, what is the volume of air that will enter the lungs? That is total lung capacity, which is for 6,000. From the point of maximum inhalation, how much can be exhaled? 4,800. That is called vital capacity. And how much remain in the lungs? That is called residual volume. It's about 1, 2. Patient with chronic bronchial asthma has increase in residual volume. No? So air na natatrap sa loob. Okay. Pulmonary function test is requested for patients with chronic bronchial asthma. Pero kung yung atake nga na yun, na reversible, okay, reversible, ay no need for pulmonary function test. Okay? So, kailangan mo lang ay treat na the symptoms. Okay. So, what are the nursing interventions? Goal, to improve airflow para maganda ang pasok ng hangin. 2, relieve the symptoms. Ano yung symptoms sa'yo? In difficulty of breathing. Okay? Yung bronchospasm na yun. Yung sikip sa dibdib. And prevent episode. Prevent episode. Una, minimize episode. Or wala na talaga dapat atake. Okay? Kaya we have to identify the allergen. Alright? And management plan includes client education, drug therapy, and lifestyle management, including exercise. Okay, so ito yung ating goals and management. Client education guide, avoid factors that trigger asthma attack. Avoid factors that trigger asthma attack. Kaya nga, kailangan examine yourself. Ano ba talaga yung nakaka-atake sa'yo? Para ma-minimize, no? Avoid factors that trigger asthma attack. Use bronchodilator 30 minutes before exercise for patient with exercise-induced asthma. And teach on the proper technique and correct use of metered dose inhaler. Provide adequate rest and sleep, reduce stress and anxiety, and they must be able to learn relaxation techniques because we have also stress-induced asthma. Failure of medications to control worsening symptoms, seek immediate emergency care. Okay? So, katulad nga wala pala siyang inhaler. O kaya kung mayroon man siyang inhaler pero sige pa rin na nahirapang huminga, edi dali na sa hospital. Ano ang mga ibibigay na gamot natin? One, of course, number one to be given is bronchodilator. Okay? So, syempre, una ibibigay natin is a bronchodilator. Ano nga yung effect? Ano nga yung effect ng bronchodilator natin? So, bronchodilator, okay? So, bronchodilators, we have three types. We have three types of bronchodilator. We have beta-2 agonists, methylxanthines, and cholinergic antagonists. Okay. Beta-2 agonists. Okay. Beta-adrenergic receptor agonists. They're also called sympathomimetics. Ayan, pharmacology tayo ngayon, ha? Sympathomimetics. So, it activates specific beta-2 adrenergic receptors, meaning it has high degree of selectability with beta-2 adrenergic receptors. And stimulation of beta-2 adrenergic receptors will lead to a broncho relaxation, bronchial dilation. It will directly relax the smooth muscles. Example ng mga gamot, albuterol or Ventolin, bitalterol, ito yung tunog terol, albuterol, bitalterol, pirbuterol, salmeterol, nakakautal. Okay? So, paano ibibigay? Ayun, through inhaler. Okay? So, press. So, they have to push down on the canister and then breathe in yung gamot. So, dapat, kung ikaw ay non-asthmatic, meron ka nito parati. Baon mo parati. Kung ikaw mag-i-eskwela, ay baon mo ito sa bulsa mo or sa bag mo. Okay? Kung saan ka man po pupunta or magbabakasyon ka for 2 days in Singapore, in Hong Kong. So, may baon ka nito. It can also be given through nebulizer. Nag-read them na kayo. Nebulization. Okay. So, napakabilis ng effect. It is given right away. Now, other drugs are methylcysteines like theophylline, aminophylline. Okay. So, since there is sympathetic stimulation, then there will be excessive cardiac and CNS stimulation. Kaya magkakaroon tayo ng tachycardia at increase in blood pressure because of sympathetic nervous system stimulation. Pero ang effect kasi nun dito, bronchodilation. Another drug, cholinergic antagonist. Cholinergic antagonist or anti-cholinergic. Ito naman, exemplified by atrovent or ipratropium. Ano naman to? It block, So this block the effect of acetylcholine. And therefore, it causes bronchodilation. Okay? There'll be bronchodilation by inhibition of the cholinergic receptors on bronchial smooth muscle. But the effect is local, it is site-specific rather than systemic effect. Dito lang dito beta-2 agonist, systemic effect siya. Okay. So, if the patient has acute asthma, if the client has acute asthma, dinala na sa hospital, a patient is given beta-2 agonist, cholinergic antagonist through nebulizer, every severe attack ha, every 30 minutes, every hour, and then kung medyo nag-improve na, every 2 hours or every 4 hours. Halimbawa, naka-beta 2 agonist siya, Ventolin nebulization every 4 hours. So, 6, 10. Ano pa susunod sa 10? 2. O, tapos meron din siyang cholinergic antagonist every 4 hours din. Pero, ito naman, 8, 12. Hindi siya sabay na sabay. Okay? Para every 2 hours, meron siyang dose of bronchodilators. Pero meron din tayong combination, no? Like Combivent, no? Combination of beta-2 agonist at saka cholinergic antagonist. Okay? So this is a client using an aerosol inhaler with a spacer. Another client is using dry powder inhaler. So this is ito mismo, no? So ito mismong size, no? Ganyan mismo din kulay. Seretide yan. Seretide. Seretide has a bronchodilator, salmeterol, tapos meron siyang steroid therapy. Okay? And another drug other than bronchodilator is anti-inflammatory drug. Ano yung mga anti-inflammatory drugs na yan? Like corticosteroids. Corticosteroids, no? Meron din tayong oral, tapos meron tayong inhaler. Okay, corticosteroids. Ayan. So yung Seretide kanina, yung violet, consists of salmeterol at saka fluticasone. Combination. Anong effect nito? Okay? Ang effect niyan, it will relieve inflammation, anti-inflammatory. And therefore, di ba namamaga? Yung pathophysiology natin, di ba? There's bronchial edema at nagbabara yung airway natin. Yung corticosteroids will reduce the edema and therefore will open the airway. Question. Are corticosteroids bronchodilator? Yes or no? Tanong. Bronchodilators? Ba ang corticosteroid? Yes or no? Sagot. Corticosteroids?
Yes.
Yes. Pero, direct or indirect?
Indirect.
Ayun, tama. Thank you, Ms. Pangilinan. Indirect bronchodilator yun. Ang direct bronchodilators, yung talagang directly relaxes the bronchial smooth muscle. So, it will open the airway kasi it will reduce the edema. It will reduce the bronchial edema. Kaya mag-open ang airway. Okay? Kaya po, for patients with acute asthma, binibigyan sila ng bronchodilator at saka corticosteroid like hydrocortisone. At ang bilis na reverse yung manifestation. Na yun yung aming faculty. Kasi cupping namin noon. So may cupping kami sa umaga at sa hapon. E then lunch, no? Sinerve, ang unang sinerve, no? Diyan sa sorry, restaurant diyan malapit sa Fatima. Pansit na may sahog ng chicken, no? Okay? At saka seafoods. Abay, 2-3 subo lang, sabi ng faculty, ma'am, kumakapal ang labi ko, hindi na ako makahinga. Dalhin mo na ako sa hospital. Oy, naku, lunch muna tayo. Sabi, ma'am, hindi na ako makahinga. Sige, di tara na. Di tara na. Lakad na kami ha, kasi malapit nga lang sa FUMC. Ayan, so binigay sa kanya hydrocortisone at saka antihistamine. Benadryl. Benadryl binigay sa kanya and a bronchodilator. Binigyan na rin siya ng oxygen, di ba? Wala pa nga mga 1 oras lang. Hindi naman kami nagtagal talaga dun eh. Okay? Pero tapos na yung kumain, yung mga kasama namin. Kasi sabi ko, naku, hindi na tayo babalik doon. O siya, uuwi na. Makakauwi na siya. Reversible. Okay, that is reversible. No? Corticosteroid. Isa sa gamot talagang ginagamit. Another, muscle stabilizer. Promoline sodium. Intal. Anong effect nito? It help prevent atopic asthma attack. It prevents mast cell membrane from opening when an allergen binds, no? Okay. When allergen binds to IgE. But are not useful during acute episode. So, ibig sabihin, though it help prevent acute asthmatic attack, pero during acute episode na nahihirapan siyang huminga, hindi ito ang ibibigay. Ang ibibigay ay yun yung direct bronchodilators, corticosteroid. Kung ganon, tsaka ito oral. Kung ganon, kumbaga, iinumin niya to for about 1 month period. Okay? Monoclonal antibodies, no, like Xolair, okay? It binds to IgE receptor sites on mast cells and basophils, preventing release of chemical mediators. Ito naman, it will also prevent the release of chemical mediators. Okay? So ito yung mga gamutan natin. Now, other than drug therapy, exercise. Aerobic exercise is recommended because it assists in maintaining cardiac health, enhancing skeletal muscle strength, no? Para malakas ang kanyang katawan, no? And promote ventilation and perfusion. Para maganda ang pasok ng hangin as well as pulmonary perfusion kasi maganda ang heart function. Swimming is another activity which can be recommended. Ayun, oxygen therapy, often used during an acute asthmatic attack. Okay? Kasi oxygen alone, no, is not the management. Kinakailangan muna i-relax natin ang smooth muscles, kailangan bronchodilation para makapasok yung hangin. And therefore, after treatment, drug therapy, oxygen therapy, ayan, no, on the right side, kita nyo, no, there is already relaxed bronchial tube. There's already bronchial smooth muscle relaxation. O tapos, nag-open na yung airway. Nababawasan na yung pamamaga. Okay? Further damage, no, will be prevented. While on this left side, ayan, iyan yung untreated. Ito yung untreated. No, so ibig sabihin, hindi nagamot, no, hindi na-address, kaya nagkaroon nga ng airway constriction, bronchospasm, bronchial edema, increased mucus secretion, kaya kung di agad naagapan, ayun, can cause sudden death. Okay. Question, bakit tayo pumunta sa bronchitis? Okay, so kung walang question, let's move on with bronchitis. So with bronchitis, it's simply inflammation of the bronchial mucosa, which can be acute or chronic. Okay, so namamagay yung ating mga bronchial tube, the primary, secondary, or tertiary bronchi. So there's inflamed, no? Primary, secondary bronchi. And acute bronchitis usually results from an infection such as cold or flu. Okay. Typically begins as an upper respiratory tract infection caused by viruses or bacteria. Okay. And what are these causative agents? It can be caused by Haemophilus influenzae, Streptococcus pneumoniae. Okay. So it can also be caused by chemical irritants, no? Noxious fumes, like noxious fumes, air. Okay. So therefore, the best way to prevent this is avoid smoke-filled environment. And therefore, madali lang intindihin. Anong signs and symptoms? Diba? There's inflammation. Hindi tulad kanina, there'll be vascular response. No? Upon exposure to etiologic agent, there will be injury to the muscles of the respiratory tract. There'll be vascular response wherein there is momentary vasoconstriction followed by vasodilation, increase in blood flow, increase in blood hydrostatic pressure, and fluid shifting from intravascular to interstitial space. At ito ay microorganism may lagnat. Okay? So patient will have fever, chills, malaise. Yeah? So there could be headache. Initially, dry, irritating, non-productive cough initially until mucopurulent ang sputum. Ano ibig sabihin ng mucopurulent? The mucus is mixed with pus. Kaya mucopurulent. Kasi the vascular response, cellular response, and cellular response is because of phagocytosis, there'll be dead organism, there'll be dead bacteria. Kaya may pus. Sasabihin ng pasyente, may nana po ang aking sputum. Anong kulay? Yellow. Okay, yellow. Maybe green. Okay? So yan yung secretion na dapat na yung plema ay hindi dudura kung saan lang. Pero di ba pag maglalakad ka diyan sa kalye, parang ang daming nakakalat na talaba. Ayun, no? So ganun ang kanilang mucopurulent sputum. And the management, virus, and the self-limiting. Okay? Pero kung tayo ay yellow color, kailangan mo ng antibiotic. So, encourage the patient, bed rest, no? Kasi syempre napapagod siya, nanghihina because of altered tissue perfusion. Kailangan mo ng antipyretic kasi may lagnat, no? And expectorant will stimulate coughing reflex kasi may dapat ilabas, no? So bigyan natin ng expectorant. And common expectorants, ha? Lahat naman siguro tayo nagkaubo na, no? Naka-experience ito. No? Ano yung mga yan? Ambroxol or mucosolvan, Flemex, no? Carbocysteine, acetylcysteine. Okay? So this will stimulate coughing para mailabas mo. Kasi antitussive will suppress the coughing reflex. Okay? Ito naman ang magsusuppress, no? Like Robitussin DM. All right? Now, you have to know the difference between expectorant and antitussive. Kasi your patient may say, nurse, bakit nung binigyan mo ako ng gamot sa ubo ay lalo akong inubo? O, kasi expectorant siya. Okay? Ang magsusuppress ay yung antitussive. Pero ibibigay lang natin yan pagka dry, irritating cough na halos hindi nakakatulog ang pasyente. Tapos pag ubo niya, masikip ang pag-ubo na naiihi siya sa panty niya. Okay? Yun ang it will suppress. Pero kung may plema na dapat ilabas, bibigay natin ay expectorant mucolytic. Okay? So, of course, encourage increased fluid intake. According to the book na sa libro din kay Brunner and Sudars, no, dating edition, the best mucolytic is water. The best bronchodilator is a deep breath. Ayun, so encourage patient, increase fluid intake, and that of deep breathing exercises. So we have to auscultate breath sounds, monitor vital signs every 4 hours, especially kung may lagnat. Okay? Hindi pwedeng, ay okay ka na po, wala ka ng lagnat. Ha? So that is undocumented fever. So dapat ay ma-assess natin, no? Yung ma-record talaga yung temperature. Encourage the client to cough and deep breath every 2 hours while awake and expectorate rather than swallow sputum. Okay? So syempre, no, gising naman ng pasyente, no, nasa bahay ba o nasa hospital, kaya kailangan bigyan mo siya ng ng sputum container and tissue wipe para doon uubo yung pasyente. Okay? Better doon na lang sa tissue wipe, no? Tapos ilagay sa plastic bag. Pwede rin sa sputum container o kaya sa kidney basin. Pero you line with tissue paper yung kidney basin. At saka yung sputum cup. Kasi pagka marami na, you need to empty. Pag in-empty mo, nakadikit yung sputum sa kidney basin. Kaya dapat may lining na tissue paper. Okay? Provide humidification of surroundings, no? Change the bedding, and client's clothes, no? Especially kung nabasa ang damit kasi mataas ang lagnat. And of course, no, offer fluid frequently. Increase fluid intake unless contraindicated. And of course, prevent infection. Teach to wash hands, hand washing, cover the nose, no? When cover the mouth, no? Cover, no? When sneezing and coughing. Sa bagay, di problema ngayon, no? Sanay na tayo, no? Na tayo ay naka-face mask, no? Lalo na si pasyente pagka uubo. Okay? And yun, no? Discard soiled tissues in a plastic bag, right? To prevent cross-infection. Avoid sharing of eating utensils and personal articles. Okay? So acute bronchitis can become chronic bronchitis. So ano ang gamot ang bibigay natin? Padayin nga ang ating mga antibiotic, mucolytic, expectorants. Acute bronchitis can become chronic bronchitis. Ano yung tinatawag natin chronic bronchitis? There's chronic inflammation of the bronchi accompanied by chronic cough. and excessive production of mucus for at least 3 months each year for 2 consecutive years. So, kung ito yung ating normal airway, ito yung normal alveoli, ito naman, no? There is chronic bronchitis, there's chronic inflammation of the bronchial tube. Tapos, maraming mucus, namamaga. At pagka paulit-ulit na namamaga, there'll be wound healing. Wound healing will be by fibrous tissue formation. Kaya there could be narrowing na ng airway. Yun ang nangyayari pagka may chronic bronchitis. Ano yung chronic cough na sinasabi natin? A chronic cough, gano'ng katagal yung ubo? A chronic cough which is present on most days of the months for 3 times in a year for 2 consecutive years. Okay, ano nga yung chronic bronchitis? A chronic bronchitis na halos sa buong buwan, may ubo siya. Ay, parang ang tagal na ng ubo ni doktor. So tuwing magkikita kami, may ubo siya. Halimbawa, 3 weeks in a month. Naubo siya ng January. Tapos, nagkaubo ulit siya noong June. And another attack in December. At least 3 times in a year for 2 consecutive years. Yun ang tinatawag natin chronic bronchitis, chronic cough. Okay? So, again, ano yung chronic cough? A cough which is present on most days of the months for 3 times in a year for 2 consecutive years. Okay? Chronic bronchitis. And again, the most common cause is cigarette smoking and long history of bronchial asthma. So, ibig sabihin, chronic bronchial asthma leads to chronic bronchitis. Also, long history of respiratory tract infection and air pollution. So, therefore, ayan, there's inflamed primary, secondary bronchi, tapos ayan, barado ang airway. Chronic bronchitis is caused most often by exposure to airborne pollutants such as cigarette smoke. Okay? And therefore, chronic namamaga yung airway, paulit-ulit, no? 3 times in a year. So there's chronic productive cough with thick, white mucus, okay? Earliest, puti pa, until there's bacterial growth, yellow, purulent, copious, madami, blood streaks sometimes, no? And there's bronchospasm. There is acute respiratory infection. Okay, kasi kung may chronic bronchitis ka, madali ka na lang magkaroon ng infection nga. And ang ABG mo, abnormal, that's hypoxemia, kaya magkakaroon tayo ng cyanosis. And even dyspnea on exertion. May sinong mahirapan na mag-pump ng dugo papunta sa lungs? It is si right side, si right ventricle. So the right ventricle will find it difficult to pump blood papunta kay lungs. Kaya magkakaroon tayo ng right side heart failure. Pag nangyari yon, chronic bronchitis na may right side failure, yun ang tatawag natin cor pulmonale. Okay? Na natawag natin cor pulmonale. Okay? Chronic bronchitis, nagkaroon ng complication of right side failure. Ayan. So, take a look. Ito yung normal airway. Ha? So, normal airway, trachea, bronchi, bronchial, okay? Patent. Maganda. No obstruction. Kaya maganda ang pasok at paglabas ng hangin. Okay, so we have good lung inflation. Inflated ang alveoli. O, tingnan natin dito. Ito yung chronic bronchitis. That there is increasing mucus secretion. Dahil madalas umatake, madalas namamaga, kaya wound healing will no longer be the same. So there'll be fibrous tissue formation. Kaya magkakaroon na tayo ng thickening, narrowing of the airway. And matatrap na yung hangin sa loob. So there's destruction and enlargement of air spaces. So there's abnormal inflation of the alveoli, air is trapped inside. At yun na yung emphysema. So chronic bronchitis can lead to emphysema. Okay? Chronic bronchial asthma can also lead to emphysema. Okay? And the culprit is cigarette smoking. Kaya ito yung itsura ng non-smoker lang. Okay? It is light porous, it lumalaki during inhalation and it becomes smaller during exhalation. Ito, hindi na bumabalik sa normal size. There's abnormal lung inflation. All right. So what are the medical management? Siyempre, just to emphasize the need for smoking cessation. Okay? And the use of same medication, bronchodilators, no? Steroid therapy, antibiotic, and of course, kailangan natin a well-balanced diet. And parating may plema, di ba? So kailangan natin ng postural drainage. This is a method of removal of secretion which work by principle of gravity. Okay. So nursing management, focus, educate the client in managing their disease, no? Especially on paano nga ba niya may titigil ang paninigarilyo. Of course, kailangan niya talaga ng willpower, no? Siya talaga ang gagawa ng paraan, no? Para maitigil, mabawasan until totally wala nang sigarilyo. Okay? And occupational counseling, monitoring air quality and pollution levels, no? Katulad ngayon, pagka panahon ng New Year o kaya fiesta, may mga putok, may mga usok, na hindi siya dapat lumabas. Okay? So, avoid yung mga overcrowded places. Avoid cold air and wind exposure because this trigger bronchospasm. Okay? Prevent infection. Avoid others with respiratory tract infection. Kailangan may bakuna sila. May bakuna sila for flu vaccine as well as pneumococcal vaccine. And nurses, we have to monitor the sputum for signs of infection and advise them or teach them on the use of meter dose inhaler. Okay? So kailangan nilang bakuna, flu vaccine, as well as pneumococcal vaccine. Now, ano yung tinatawag nating emphysema? Emphysema is a lung condition wherein there is loss of lung elasticity and hyperinflation of the lung. So this is the most common form of COPD. Na, andito ang ating airway pattern, airways pattern, kaya ang ganda ng ating alveoli. Tapos, ang ganda ng ating alveolar membrane. Alright? Tapos dito, take a look. Take a look din eh. Compare dyan. Ito, nagkaroon tayo ng airway obstruction. Probably secondary to a chronic infectious or inflammatory process. Kaya nagkaroon ng healing process by fibrous tissue formation. Kaya narrowed, makipot ang daan. And air is trapped inside. Kaya tingnan mo yung alveolar membrane, no? Nasisira na ang mga alveolar membrane, numinipis at puputok. So, puputok ito at pag pumutok yan, there will be release of air. Ang tawag doon na lumabas dito sa nag-rupture na alveoli is bullae or bleb na mag-accumulate yan in between alveoli. In between, di ba? One alveolus, one. In between alveoli, there'll be air na nanggaling sa nag-rupture na alveoli. Okay. So, anong etiology? The major cause pa rin is smoking. Pero, kung minsan, may pasyente na hindi smoker, pero nag-emphysema. Okay? Because, no, yun nga yun, there is genetic predisposition. Okay? Sometimes, it can also be secondary to air pollution, pero minimal. So, we have here, no? So, we have the enlarged view of air sacs or alveoli. The cigarette contain many hazardous substances that damages the lungs when inhaled. Yun ang simple term, no, para maintindihan natin. So there are several substances in the cigarette, which when inhaled are hazardous to the lung structures and damage the lung. E punta naman tayo dito sa alpha-1 antitrypsin, AAT. AAT, alpha-1 antitrypsin. Kahit hindi siya smoker, no? Pero pwede siyang magkaroon nito if there's deficiency of AAT. Ano ba to? It is made by the liver and is normally present in the lungs. Okay. It is normally present in the lungs. Ano yung function? It regulates proteases from working on lung structures. It is protective in nature. Alpha-1 antitrypsin. Kaya pag kulang yon, no, if deficient, COPD can develop kahit hindi siya naka-expose sa cigarette smoke or other irritants. Okay, so it regulates proteases from working on lung structures. So nagkakaroon po ng disequilibrium between elastase and anti-elastase. Kaya nagkakaroon ng destruction of elastic recoil. Nagkakaroon ng over distension of the alveoli at retention of carbon dioxide. Okay? Again, because of deficiency of alpha-1 antitrypsin, nagkakaroon ng disequilibrium between elastase and anti-elastase. Kaya nasisira ang lung structure. There's loss of elasticity. Air is trapped. Air is trapped. Kaya abnormally inflated and distended. Na pag yan ay pumutok, air will accumulate in the in between alveoli, and that is called bullae or blebs. Tapos pupunta sa pleural cavity. So that's the cause of spontaneous pneumothorax. Okay. So initially, ang pasyente is pinkish in color. Maganda ang kulay niya. Komportable at rest. Only becomes dyspneic upon exertion. Pero kung nag-rupture na yung alveoli, there'll be decreased area for gas exchange. So therefore, kung rupture na yung alveoli, walang gas exchange yan. Kaya magkakaroon tayo ng impaired, ganda ng exchange. There'll be impaired gas exchange. Kaya si patient becomes dyspneic even at rest. Diba nung una, pan-exertion lang eh. And because of parati siyang, even at rest parati siyang nahihirapang huminga, always gasping for breath. Increased energy expenditure. Gumagamit siya ng maraming energy. Kaya si pasyente, nangangayayat, emaciated, thin, and emaciated. Okay? So, andito yung comparing the normal lung with that of a COPD lung. Okay? So, di ba? Andito yung dalawang lungs natin. Tapos, andito si diaphragm with normal curvature. Okay? Over here, there's flattening. There's flattening of the diaphragm. Saka tingnan mo dito sa lung, compare dito sa right lung. Malaki siya. No? So, it is enlarged because of air being trapped inside. Okay. So, what are the classification? Classification, may panlobar, panasina, pero naisuno na lang to. Okay. Kahit local or NCLEX question, walang lumalabas na question on the types. Anyway, basta yan, ito yon, malalaki ang mga alveoli. Pag nag-rupture, mag-accumulate in between the space, so that is bleb or bullae. Okay, o dili kaya dito sa centrilobular. Okay, ang enlarges. Ayan ang mga malalaki. All right. So, what are the assessment findings? Sabi ko nga, the patient is pinkish in color. Patient is comfortable at rest. Only had DOE. Dyspnea on exertion. Ayan. So, the first symptom, exertional dyspnea. Nahirapan silang huminga even with minimal activity. And syempre, yung may ubo pa rin, chronic cough with mucopurulent sputum, Bakit magiging mucopurulent sputum? Diba? It can be a complication of chronic bronchitis and chronic bronchial asthma. Of course, there'll be decreased breath sounds, no? There's wheezing, crackles, and barrel chest. To accommodate the air which is trapped inside, there'll be change in structure. There'll be increase in anterior posterior diameter of the chest. And of course, use of accessory muscles of respiration. There is a tension of carbon dioxide now, no? Kaya there'll be respiratory acidosis. Carbon dioxide is retained. So, anong effect na to? This will cause CNS depression. There'll be altered level of consciousness. Lethargy, okay? Disorientation, stupor, which can progress to coma state. So, the fundamental problem in emphysema is the loss of lung elastic recoil, causing the respiratory bronchioles to collapse upon expiration. Okay? At sabi nga, the usual cause is tobacco smoking. So in here, so there's strong hypercarbic drive. Patient struggles, no? Okay. So they are called pink puffer. Okay. Kasi di ba initially, they are pinkish in color and gasping for breath. While dito, this is chronic bronchitis. No, si chronic bronchitis, they lost hypercarbic drive. Does not struggle, unlike dito sa emphysema. Pero namamanas siya and cyanotic. Kasi nagkaroon siya ng right-sided heart failure. So ang tawag sa kanila, other name, blue bloater. So what's the other name for emphysema? Pink puffer. Sa bronchitis, blue bloater. Alin dyan? On the left side, sino yan? On the left side.
Pink puffer.
Correct. Yan ang emphysema. Pink puffer. Okay, while dito sa right side, ayun, no, di ba, namamanas, blue bloater, chronic bronchitis. Okay. So the medical management, no, tulad ng introduction ko kanina, pare-pareho lang sila, bronchodilator, mucolytic, antibiotic, corticosteroid, no, and the breathing exercises, postural drainage, chest physiotherapy. Okay. Nursing management, administer oxygen via nasal cannula, about 2 to 3 liters per minute. No? Because high flow of oxygen may lead to loss of hypoxic drive. Diba? Normally, tayo, our primary chemical stimulus for breathing is slight increase in carbon dioxide, and secondarily, by low levels of oxygen. It will stimulate the main respiratory center, which is the medulla oblongata, to increase the rate and depth of breathing natin. Pero si patient na may emphysema, may COPD, they are used to retention of carbon dioxide. Kasi parati mataas ang carbon dioxide. And therefore, their primary stimulus for breathing is low level of oxygen. Kaya bigyan mo lang siya ng low flow. 1, baka hindi niya maramdaman yun. 2 liters, ayun, 3 liters of oxygen so as not to lose the drive for breathing. Okay, meron tayong NCLEX question. Yung pasyente may emphysema. O, tapos nagpunta yung nurse, no? The nurse go to the patient. Tapos na-assess niya, nahirapan huminga ang pasyente. Eh, kaya naman pala yung oxygen lang pala niya, 2 liters. Kaya pala nahirapan huminga. Hindi niya masyado pang kilala yung patient. In-increase niya to 10 liters of oxygen. O ano nangyari? The client lose the drive for breathing at nag-respiratory arrest yung pasyente. Okay? So, dapat low flow of oxygen. They teach also abdominal breathing, no? Using diaphragm effectively at saka pursed lip breathing. Ayan yung mga breathing exercises. Okay, later. So, ang general appearance, ayan, si pasyente, okay, thin, makapal ang dibdib, mabilis ang RR, no, 40 to 50 breaths per minute, makapal ang dibdib, there's barrel chest, okay, and there's cyanosis, there's clubbing of the fingers, okay? So, ano nga yung normal? Normal clubbing, less than 160 degrees, no? At ito, more than 180. Okay, yan yung clubbing. Okay, tapos bulus yung fingers niya. Okay. And also manifestations of right-sided heart failure, no? There is leg edema. Okay. Na yung parallel chest, okay, ito yung normal anteroposterior diameter of the chest, and there's increase in anteroposterior diameter of the chest, makapal ang dibdib sa likod at harapan, which is very evident when the patient is in supine position. Okay? Barrel chest, basta nakita nyo barrel chest, there's emphysema. Psychosocial assessment. Socialization may be reduced. Pwede siyang iwasan ng kanyang mga kaibigan, ng kanyang mga kakilala. Kasi naiirita din sila doon sa chronic cough and excessive sputum. Or yung dyspnea, okay lang. Pero yung annoying cough, no? Na kumakain, tapos kasama mong kumain, tapos bigla na lang uubo nga yung matunog at alam mo, maraming plema. Pwede ka iwanan ng kaibigan mo. Pag iniwanan ka ng kaibigan mo, hindi true friendship yun. Okay? So, pero other person na hindi naman talaga niya kaibigan, ay lalayo na sa kanya. Kaya one problem, one nursing diagnosis, social isolation related to annoying cough, excessive sputum. Okay. Kaya, dapat talaga mayroon siyang face mask. Alright? Lalo na pag uubo. At kung kumakain at mauubo, pwede naman pumunta sa CR o lumayo. Okay? Laboratory assessment. Of course, there is abnormal ABG. Sabi nga natin, there's retention of carbon dioxide and there's hypoxemia. Sputum culture. Bakit kailangan natin ng sputum culture? Para ma-identify anong mikrobyo, what microorganism will grow on that culture medium, para malaman natin which antibiotic will be given to the client. So, siyempre, bibigay natin antibiotic na sensitive to. Yung mikrobyo sensitive to that antibiotic, yung resistant, hindi dapat ibigay kasi resistant naman pala doon yung mikrobyo. Now, we are more concerned on collection of the specimen. When are you going to collect the specimen? The client, you receive an order, no, for sputum culture. In most instances, when is the best time to collect the sputum? Morning, afternoon, or night?
Morning.
Okay, correct. Bakit sa umaga? Okay, bakit sa umaga kinokolekta ang sputum? Okay, bakit sa umaga? Bakit sa umaga? Kasi, huwag niyo sabihin na kasi hindi pa siya kumain. Kasi pwede rin naman before lunch and before dinner, hindi pa siya kumain. Pero ang pinaka-logic doon, kasi sa umaga, syempre natulog ang pasyente. Kahit sabihin nahihirapan siyang matulog, pero kahit pa paano natulog, nabawasan ang pag-ubo niya kasi nakatulog ang pasyente. Maraming naipon. Anong naipon? Secretion, mucus. Kaya magkokolekta tayo sa umaga. Sigurado, makakakuha tayo ng good specimen in the morning. Another question. With mouthwash or no mouthwash? Mouthwash or no mouthwash?
No po.
Correct, no mouthwash. Pero, another question. Iba namang question, ha? Ibang pagkakataon. Mouthwash with plain water or with antiseptic solution? Ibig sabihin pala, pwede palang mag-mouthwash. Kasi yun ang situation eh. Yun ang nakalagay doon sa question. No? Plain water or antiseptic solution? O, anong gagamitin?
Plain water.
Ayun, plain water. Huwag kang gumamit ng Bactidol, Listerine. Plain water lang. Para hindi ma-alter yung ating environment. Okay? Ngayon, give patient a sputum container, wide mouth bottle, sterile, para doon mismo ilalabas yung secretion niya. Iupo ang pasyente Teach patient to do deep breathing, at least 1, 2, 3, 4, 5 breaths, and then forcibly cough out the phlegm. Forcibly cough out the phlegm. Hindi yung dudura lang siya sa sputum container. Dito lang yun, mucus lang yun dito. Forcibly cough out the phlegm. Wide mouth battle. Huwag kayong magkamali, no? Na baka kasi ma-assign kayo doon sa malayong lugar, sa probinsya, so walang sputum container, ginamit mo yung vial na, alam mo yung mga vials po na ginagamit natin, vials sa mga medications, ginagamit namin yun, nire-reuse, ni-sterilize, para yun ang specimen bottle. May garamycin, si garamycin, gentamicin, maliit lang yun. Huwag mong gagamitin yun. Dahil pagka naglagay ng plema yung pasyente, nandito lang sa mouth of the vial. Hindi mo makuha sa pasyente. Okay? Nadidiri ka. Kaya give wide mouth bottle or specimen container. Alright. Ngayon, kung si pasyente ay naka-endotracheal tube or naka-tracheostomy tube, syempre, do not expect the patient na uubo siya ng plema. Okay? The fact na siya ay naka-endotracheal tube, most probably with altered developed consciousness ang pasyente. So you suction your patient. Endotracheal tube suctioning. O kaya tracheostomy suctioning. Kung tracheostomy tube meron siya, gagamitin mo bagong suction catheter. Bagong suction catheter. Suction the patient. And then, mabilis ka ha? Mabilis. Huwag mong bayaan na yung secretion ay pumunta dito sa collecting bottle. Wala kang makukuha. So, bagong-bago na suction catheter. Matapos, no, matunog, nakakuha ka ng plema. And then, yun ang ikakat mo into small length, no? Tapos ilagay mo sa container. Yun ang isesend mo mismo sa laboratory. Okay? O kaya tracheal aspirate. Ayun. Kasi 3 days nang ni-order ni doktor yung sputum culture. Nurse, nasa na yung result ng sputum culture? Tracheal aspirate. Dok, wala pa po. Kasi wala pa pong binibigay na specimen yung pasyente. Hoy, ako, mapapagalitan ka talaga ng doktor. Anong hinihintay mo na ibigay nila? Si nurse mismo ang magko-collect na. Okay? Yan ang ginagawa namin, no? Sa ward, lalo na sa ICU. Kasi sa ICU, intensive care unit, no? Ay kadalasan, meron silang endotracheal tube or tracheostomy. Alright. Hemoglobin, hematocrit. Ano kayang result? High or low? Hemoglobin, hematocrit, high or low? Diba? There is hypoxemia, altered tissue perfusion. So, hemoglobin is low. Okay. Hemoglobin is low. Analyze. Mababa kaya o mataas? Hypoxemia, altered tissue perfusion. Altered perfusion kay brain, altered renal perfusion. We decrease oxygen in the kidney. Diba? There'll be renal hypoxia. Then, the kidney will produce erythropoietin. Erythropoietin will stimulate the bone marrow. Okay? Erythropoietin will stimulate the bone marrow to produce RBC. Balik sa question. Hemoglobin. High or low? Hemoglobin now is high. Correct. Mataas ang hemoglobin. Okay. Pero yon ay secondary. Compensatory lang yon. Kasi compare with a client, no, with polycythemia primary. Ano yung polycythemia primary? Wherein there's abnormal proliferation of bone marrow cells. What are the blood cells which grow in the bone marrow? Not only RBC, but also platelets as well as WBC. Sa primary polycythemia, lahat ng blood cells mataas. Yun ang cancer of the blood. Pero si patient, ang mataas lang, hemoglobin. Kaya that is polycythemia secondary. Okay? Serum electrolyte levels, bakit kailangan pa dito ng serum electrolytes? Di ba, earlier sabi ko nga, baka kaya naman pala nahihirapang huminga, there's respiratory paralysis. Ay simple dahil lang sa electrolyte imbalance. Kaya kailangan niya ng isang beses lang naman, hindi monitoring yun. Yung electrolyte, determination of serum electrolytes. So particularly, baka mababa yung potassium. Okay, hypokalemia can cause weakness of the respiratory muscle. Para ma-address ang cause, bigyan siya ng electrolyte supplement kung kinakailangan. Of course, another diagnostic test is just a chest x-ray. Chest x-ray para ma-rule out baka may iba siyang chest diseases. At malalaman natin kung nag-improve ba siya or nag-deteriorate ang pasyente. Chest x-ray. No? Ideally, chest x-ray is about once a year or twice a year. Ito, i-monitor natin, iuulitin ang x-ray para ma-check yung progression or nag-improve ba si patient. And of course, the pulmonary function test. No? The volume of air that enter the lungs with normal effortless breathing, tidal volume. Pag ang pasyente nag-do deep breathing, the maximum volume of air na papasok sa baga, total lung capacity. From the point of maximum inhalation, ganong ilalabas niya, vital capacity. Ganong na tira, residual volume. Okay. So therefore, mainstay of COPD management. Anong mainstay? Airway maintenance. Monitor natin. Drug therapy. Oxygen therapy. Okay. First, airway maintenance. Para maganda ang pasok ng hangin. So, keep the client's head, neck, and chest in alignment. So, ibig sabihin, kung ang patient, di ba, patient, semi-fowlers, or sitting really upright. O kaya, yung pasyente nakaupo, tapos yung kamay nakapatong sa armchair, tapos leaning forward, orthopnic position. Kung ang pasyente nakaupo sa bed, nakaupo siya sa bed, dapat align, tapos lagyan ng unan to support the chest, neck, at saka ulo. Hindi yung unan dapat naka-vertical. Hindi yung horizontal ang unan. Horizontal, hanggang sa likod lang siya. Kaya anong nangyari sa neck? Hyperextend. Hindi komportable ang patient. Okay? Yun ang ibig sabihin ng client's head, neck, and chest in alignment. Assist the client to liquefy the secretion. Okay? Provide adequate hydration. O kaya yung mga gamot natin, mucolytic. Okay? And breathing techniques, deep breathing exercises. Ano yung mga deep breathing exercises na yan? Ayan, yun yung tinatawag natin diaphragmatic or abdominal breathing. Subukan nyo nga ngayon, no? Subukan nyo ngayon, no? Na kayo ay nakaupo, no? Or kung si patient, no, ay nakahiga, lie on back with the knees bent para relax din ang abdominal muscles. Tapos lagyan ng libro, or lagay ang kamay, kayo, ilagay ang kamay sa tiyan. Inhale, exhale. Inhale, exhale. So papasok ang tiyan during inhalation, lalabas during exhalation. Hindi yung nahirap ako huminga noon pagka tumataas ang balikat mo. Okay, so diaphragmatic breathing. Another is first lip breathing. Okay, so ito yung tinatawag natin first lip breathing na close your mouth. No, close your mouth and breathe in through the nose. Close mouth and breathe in through the nose. And then purse your lip as you would do whistling. Para ka mag-whistle. Breathe out slowly through the mouth without puffing your cheeks. Okay? Anong effectiveness nito? So inhale, then wala kasi akong tunog eh. Prolonged exhalation. Para mailabas ang carbon dioxide. It will minimize air trapping. Parang, in simple term, birthday, blow the candle. Mag-wish muna. Ayan, tapos, blow the candle. Diba? Hindi yung, ang bilis. Okay? So, mas mahaba yung exhalation kesa inhalation. Yun ang first lip breathing. At meron din tayo na nag-rate them kayo, incentive spirometry. Nag-demo? Nag-return demo?
Yes, ma'am.
Oo, may mouthpiece yun, no? Dahil kailangan ma-maintain mo yung ball at that level. Okay? So, ibig sabihin, you are doing prolonged exhalation. That is a good breathing exercise. Okay? And then, ito naman, ito nga yung percussion and vibration. Percussion will mobilize the phlegm. Okay, percussion, para matanggal ang pagkakadikit-dikit, mabakbak, sa Tagalog, mabakbak yung phlegma. And it will mobilize, na? It will be mobilized with vibration. It is best done, no, during exhalation. Ayan, no? Percussion and vibration. While ito is a process of removal of secretions which work by principle of gravity. So that is called postural drainage. Okay? Ngayon, ang posisyon ng pasyente, iba-iba. If we want to drain the lower lobe, syempre, ang pasyente, naka-Trendelenburg. No? Position the patient on his back, tapos lateral, and then on his abdomen. At least 15 minutes each position. Kaya pagka nag-postural drainage ka, more or less, isang orasyon. But if you want to drain the upper lobe, consider the structure, no? Upper lobe, the patient is seated and then advised to lean forward, backward, and sideways. At napaka-importante, no? To do oral hygiene. So it will promote drainage of secretions which work by principle of gravity. At least, no, kung nasa lower lobe, no, at least yung phlegma, mga secretion, makarating sa bronchus, madali nang mailabas or madali nang isaction si patient. Okay? Now, patient has an order for postural drainage 3 times a day. 3 times a day. Board question. Which is among this time, which is least desirable to do postural drainage? Before meal, after meal, or bedtime? List like in between meal. Okay, anong choices? Before meal, after meal, in between meal, bedtime. Which is least desirable?
After meal.
After meal.
Bakit?
Bagong kain lang.
And so? Tapos tinawag-tawag mo. Diba? Tinawag-tawag mo yung pasyente. Kinabog-kabog mo. Anong pwede mangyari? Patient can vomit and cause aspiration. Yon. Pag before meal, napagod, maaaring hindi siya makakain. Pero iba naman pasyente, pag pagod, mas malakas kumain. Bedtime, napagod, pwede siyang hindi makatulog. Pero iba naman, pag pagod, mas nakakatulog. Walang risk of injury. Diba? Di tulad nung after meal, tapos nagsuka si pasyente. Ayun, there's danger of aspiration. Ayan, board question yan. Least desirable. Least desirable. Okay, ayan, no? It works by principle of gravity. Okay, so in here, the nurse, no, is doing postural drainage for a client with respiratory problem. Monitor. Ano yung monitor natin? Of course, we have to assess the patient every 2 hours. Ano i-assess? We have to assess the vital signs. We have to assess the level of consciousness. No? So, kung siya ay mayroon ng cor pulmonale, right-sided heart failure, kailangan i-monitor natin intake and output. Monitor the character of the sputum, the color of the sputum, the amount, okay? Monitor ABG, monitor O2 saturation, monitor lung sounds. Okay, O2, oxygen therapy. Diba sabi nga natin, we have to give low flow of oxygen. Okay, so ang effectiveness ng oxygen therapy can also be evaluated by ABG and O2 saturation by doon sa pulse ox. Usually, may books na iba nagsasabi 2 to 4 liters or even 1 to 2 liters. At pinaka-safe talaga, 2. Pinaka-safe, 2 liters of oxygen. Pagka makakabigay dahil tayo ng oxygen up to 40%, mas maganda via Venturi mask. Okay? Low flow of oxygen, sabi ko nga, so as not to remove the drive for breathing. oxygen therapy, drug therapy. So, same inhaled and systemic drugs for asthma. Like yung ating mga mucolytic, acetylcysteine, okay, guaifenesin, ambroxol, mucosolvan, Flemex, okay, and monitor also your patient for complication. And the most common complication is pneumonia. This is the most common complication. And therefore, teach to avoid large crowd and stress the importance of receiving pneumococcal vaccine and flu shot. Pneumococcal vaccine is every 3 to 5 years, while flu vaccine is once a year. Ayan, so dapat may bakuna sila. At karaniwan naman talaga may COPD yung mga matatanda. No? So talagang it is a must na may vaccine sila. How about, okay, so these are the complications, no? Hindi lang pneumonia, but there's also hypoxemia, respiratory acidosis, respiratory infections nga, kasi parati silang may plema eh. And therefore, it promotes growth of microorganism. And sa puso, cardiac dysrhythmias and core pulmonale. Okay. Ay ano nga bang diet? Ano nga bang diet applicable for patient with COPD? High carbohydrate, high or low?
High.
Ano ang carbohydrate? Dapat low. Because the natural end product of carbohydrate metabolism is carbon dioxide. Diba? They have difficulty excreting carbon dioxide. Protein. To promote tissue repair. Ede dapat high protein. Fats. Siyempre, healthy diet naman is low fat. Ayun. Advice on small, frequent meals rather than 3 heavy meals. Kasi pag sila ay sobrang busog, mahirapan din silang huminga. Kasi pag sobrang busog, kasi the diaphragm, mahirapang bumaba, di ba, during inhalation. Advice on small, frequent meals. Okay, for patient with chronic bronchial asthma, allergen, ang diet niya, hypoallergenic diet. So we have to coordinate with the dietitian. Okay, so nurse coordinate with the other members of the health team. Okay, last, bronchiectasis. Ano naman yung bronchiectasis? This is abnormal and permanent dilation of the bronchi and bronchioles. Abnormal, permanent dilation of the bronchi and bronchioles. It results from inflammation and destruction of the structural components of the bronchial wall brought about by chronic inflammation, chronic infection, pwede rin secondary to tumor or foreign body or congenital abnormality. Ayan. Ayan ang bronchiectatic lang. Tignan mo, oh. There is abnormal permanent dilation of the bronchi and bronchiole. Bakit? Because of chronic inflammation. Kasi si pasyente nagkaroon ng chronic bronchitis. Nagkaroon siya ng chronic bronchitis. Ito sabi natin, wound healing, no? Will be by fibrous tissue formation. Dahil abnormally dilated, naiipon dito mga purulent materials. Naiipon dito yung mga plema and therefore will become more dilated. Dahil nag-dilate na, maraming plema, it favors bacterial growth. E more infection. Okay, e plema pa more. Infection pa more. Ay, Diyos ko, parati silang may plema, foul smelling. Okay, ito ibig sabihin no? The structure of the wall tissue changes resulting in saccular dilation. Ayan. Matapos may ipon ang maraming secretion, causing more dilation, damage, and more infection. Parati silang may phlegma, bronchiectasis. There's chronic cough. Copious, purulent, blood-streaked sputum. Na coughing worsen when the client changes position, no? Especially pag siya ay nakahiga. Siyempre, ano ang ABG? Hypoxemia, respiratory acidosis, activity intolerance, kaya fatigue, weight loss, nangangayayat sila. No? And makikita by chest x-ray, yon, chest x-ray, as well as bronchoscopy. Ano ang bronchoscopy? It will reveal increased size of bronchioles, atelectasis, and changes in pulmonary tissues. Ano yung bronchoscopy? Bronchoscopy from the word is direct visualization of the bronchial tube. Okay? Fiber optic bronchoscopy. A lighted flexible tube, ipinasok hanggang doon sa bronchial tree. Kaya mabivisualize yung inside. And that is also the best time to collect the specimen for sputum culture. Okay? So yon. So kung hindi man siya nag-bronchoscopy, kailangan din natin ng sputum culture dahil parating nga silang may plema, bakit hindi na-address yung infection? Balikan natin sa bronchoscopy. Instrumentation is done para ma-visualize sa loob. Anong nursing responsibilities? One, obtain consent. Obtain consent. Explain the procedure. Although this is primarily the responsibility of the doctor. Oral hygiene is a must. No? Offer oral hygiene, remove denture. Take the baseline vital sign. Okay? After the procedure, this is done under anesthesia. Topical anesthesia, silocaine spray. During bronchoscopy, dapat na-monitor yung O2 saturation, kaya naka-pulse off at may nakahandang oxygen therapy. Okay? So, sa Fatima, ginagawa ito sa OR complex. Okay? Endoscopy. All right. After the procedure, maintain on NPO until gag reflex returns to normal. Save the sputum. Siyempre, you observe yung sputum, yung mga first sputum, medyo blood streak yun. That's normal because of instrumentation. Okay? So, anong management? Ito rin. Sabi ko yung introduction ko kanina, di ba? Drainage of purulent material, chest physiotherapy, chest percussion, vibration. Ako, makikinabang talaga ang pasyente sa postural drainage. Antibiotic, bronchodilators, mucolytics, humidification, and surgery or removal of bronchiectatic lung. Halimbawa, one lobe is affected. E di tanggalin yung one lobe. Lobectomy. Or one segment lang ng lung. Segmentectomy. Okay? Kung naoperahan ang pasyente, of course, no, pre-op, prepare the patient, pre-op, obtain consent, explain the procedure, kinakailangan po, gagawa kayo, deep breathing and coughing exercises. No? And importante is positioning after. Positioning after. Halimbawa, ang operasyon niya ay right side, right side. So, the goal of the positioning is to promote lung expansion of the affected lung. So therefore, the patient can be on his back, semi-fowlers, no? And can be turned to side. When turning to side, affected lung or unaffected lung? Last question. Affected lung or unaffected lung? Anong goal of positioning? To promote lung expansion of the affected lung. So therefore, ang position natin, unaffected lung. Okay. So tingnan natin kung may nag-chat dito. Correct. Thank you. Thank you, Noemi Densyo. Okay. Tama. Unaffected side. Uy, maraming board questions sa ganyan, ha? Kumbaga, you have to analyze. No? So, para mag-expand yung right lang, edi position. Left side. Okay. And of course, other interventions, no? Promote wound healing, care of the wound care, observe the wound for signs of infection, antibiotic again will be given, no, in order to prevent wound infection, encourage the breathing and coughing exercises, encourage early ambulation. Mas mabilis na nakalakad ang pasyente, mas favorable para sa patient. So there'll be faster wound healing, less or no complication at all. Okay, I guess this is the end of our lecture for today. May isang slide pa pala. Ayun, instruct client of postural drainage. Ayun nga, CPT, oral hygiene. Okay? Oral hygiene is napaka-importante, no? Lalo na kung Kung di man siya naoperahan, oral hygiene, di ba? Mucopurulent ang sputum nila. So, kailangan ng oral hygiene kasi magkakaroon sila ng halitosis or bad breath. For comfort of the patient, kailangan talaga ng oral hygiene. Okay, so next meeting, week 4. Week 4 is tomorrow. Week 4 is next week. So tomorrow is asynchronous tayo. So gawin na ang mga course tasks na kinakailangan or discussion board due for prelim. Kasi week 4 na po tayo next week. Susunod week 5. Tutuloy natin, tatapusin ang lung disorders. Tapos sa week 5, the blood disorders and blood vessel disorders. Tapos week 6, prelim exam na tayo. Napakabilis po ng panahon. Okay? Kung sino man po sa section ko, section 4, section 13, no, na nakamiss ng quizzes, I will give the special quiz on Sunday, starting 1 p.m. Starting 1 p.m. Please send the consultation form. Okay? Pwede, kung sino man yung leader, pakisummarize na po sa GC. Pakisummarize na po sa GC. Yung, halimbawa, quiz 1. Disturbance and pumping mechanism. Si Santos, si Reyes. Ayun. I-summarize na po, please. And huwag kaligtaan yung consultation form. Consultation form can be sent dito na rin sa GC. Huwag na po doon sa email. Napupuno po ang email, di ba? Konti na lang po ang nawawala po ang mga email. Kasi kung ilang gigabytes na lang po ang binibigay sa mga faculty. Ganun din sa estudyante. Okay. So, section 4. Ask ko lang po kung ano po yung possible topic po sa oral revalida. Okay, thank you. Ito ay na-explain na rin namin doon sa kahapon na nag-lecture. Ito po kasing oral revalida na to ay nakaplano ito even before 1 month before the semester starts. At ang pinapayagan lang po duty noon ay oral, OR and DR. Di ba? 2 weeks ago, or 3 weeks ago na ba yun, nagpayag na po ang CHED, NIATF, at yung Fatima, school natin, na pwede na kayo mag-hospital duty, kaya nagkaroon na ng exposure sa hospital, the medical ward, surgical ward, CHN. Kaya po, yung oral revalida, initially, ang plano dyan, yung mga, you will be presenting a case. Pero ngayon, case presentation will already be done after your rotation. That's why in your rotation, your CI will require you, especially in the medical surgical ward, the CI will require you a daily nursing care plan, drug study, at saka case study. At mamimili kayo ng isang case to be presented. Okay, to be presented with your clinical instructor. Kaya yung case presentation will be done na by your own clinical instructor. At ang coverage na lang ng skills lab ay at least matapos nyo na lahat, hindi lang OR procedures, hindi lang RESPI procedures, renal activities na may dagdag din na konting activity para sa CHM, Cangeria, at saka ONCO. Yun ang tatapusin. Pero wala na yung oral revalida na maghaharap-harap tayo and you will be discussing a particular case. Okay, wala na po yun, no? Kasi F to F na tayo.